Okay, so good evening, welcome. Thank you for being here. This is sort of our pre-holiday party. Before we kick it off, I do want to recognize some sponsors and partners. HP, of course, our main host, UCSF Health Hub and Vator. But there are other partners as well who support this salon series. And we have Avison Young, and where's Anthony? Avison Young is a commercial real estate company. You'll hear from him, so if you guys need office space, talk to Anthony. We have StratPoint. They're our outsourced engineers, so Mati is right there. They've got a couple hundred engineers now. They do a great job. And then we have Scrubbed, which is they do our back office accounting, and they work with a lot of startups as well, and Advisor, which is an investment bank for a lot of startups as well. So any interest there, just ask me. But they do support this event, so I do want to recognize and thank them for supporting this event.
Yes, and welcome. And of course, besides the festivity, this is a 2-year mark for Invent Health platform. So thank you for joining. We have started from value-based care, went into future of doctors and clinics and mental and behavioral health, and talked about vitality, what it takes for all of us to feel kind of the best version of ourselves. And here we are talking about insurance, and it has nothing to do with the politics outside. I promise. Somewhat, right?
Might bring it in.
Might bring it in, yes. So yes, we're talking about what the future of health insurance looks like, and we thought we would like to hear from folks from the industry. What are the things that they're doing that's relevant to each one of us, affects us personally, but also affects our bottom line too, as an organization. So welcome to the event today.
Yeah, and so so we said that we were going to sort of summarize. So my little summary of what's happening in healthcare, and I'm glad actually that you're interested in this topic, healthcare insurance. I think it's a little dry, certainly not as emotive as lifestyle as a drug, which was one of our other events, and mental health, which is extremely popular. And by the way, it's March 25th next year at UCSF, so if you're interested in that, that's our most popular event. You can sign up now for a discount. And just quickly before I jump into healthcare, we have our 2020 lineup. And so the future of mental and behavioral health is March. Then we're going to have in-home devices.
Yes.
And then after in-home devices, we're going to do wellness, vitality. That's in September. And then we're going to wrap it up, I think, with female health.
Yes,
so,
there is a lot of activity in gender health in general.
Yeah.
Because,
So that's, so then we have healthcare insurance, which is today. But yes, it is really important, right? It is the means by which we actually pay for our health care. But there's a problem. Just speaking to Shawn, and he said, a lot of people aren't awakened to this, the problem with health care, and that's a great word. They're not, but I think there is an awakening to the realities that the system is pretty broken, because some of the numbers just show it. Premiums are up 400% over 20 years. 40% of those people who are, 40% of people, adults who are get insurance from their employers can't afford it. That's 40%. That's quite a lot. Obviously, we have a very public debate about the government stepping in to control our finances, because clearly we're not showing that we're managing and being good stewards of those finances. And then a couple other things is that there's a real disconnect, I think we all feel, between the way we engage with healthcare or not engage with the healthcare services, and the way we interact in the other parts of our life, where everything is transparent, where we have more control, where we actually have tons of options. And it's one of the reasons why I think that health insurance companies have a bad reputation, right? Because they don't do this. It's like a black box. They're very opaque. So I think it's like 85% of Americans don't trust their insurance company, or they feel that insurance companies put profits over patients. And then the other trend over the last 5 to 7 years is that we've got all of these new tech companies, these emerging tech companies that honestly, I think if you boil it down, they're using, they're doing tons of things with data, but what they're trying to do is build trust between the consumer and the insurance company.
Yeah.
Build trust that probably was never there. So for me, my questions are, do we hand it over to the government? And oh, by the way, people don't trust the government either, so I'm not quite sure we want to do that. Or do we make it more transparent for the consumers so they can actually engage with their health care?
Yeah, and I think it is, we did a survey for each one of you. I'm sure you have answered some of the questions, and these surveys are also trending in that direction. People actually trust their self-insured employers' insurance a little bit more. And so, no pun intended for all of our speakers, but we really want to know about how, health insurance has a trust problem. What are the things that we are doing? How are we engaging folks into getting more involved with their healthcare insurance, becoming a savvy customer of a consumer of healthcare in general, not just thinking their doctor, but also thinking the finance, the business side of how they are financing their healthcare in general. Some of the numbers are staggering: 300% increase in house prices, but 400% increase in the out-of-pocket healthcare cost. That is unsustainable for each one of us, whether you are part of the insurance industry or you're outside the insurance industry. It hits all of our bottom line. So we want to talk about what are the innovative things that are happening. How are we managing risk? And we talk about risk as if each person is carrying a risk with them, but that's essentially a way to measure how do we assign dollars to a certain population, a certain individual. So we want to hear a little bit more about how do you manage that. So with that, we would like to invite Shawn.
And by the way, this is very interactive. We do want you to raise your hand and get involved and actually ask questions. We want to hear from you. We have a really smart crew. And Shawn, let's do it over here. I know this is an interesting setup
have
here.
Our cozy corner right in. Yes.
All right.
So, and then this mic works. There. And Shawn Wagoner, everyone, he's one of the co-founders of Bind Benefits.
Yes, so generally our format is we cannot do a better introduction of you than you yourself. So if you can kind of talk about yourself and then also give a slight overview of what Bind is, and so we all get to know a little bit. I know, Bambi knows, but
yeah, by the way, I'm the timekeeper, so just don't mind.
How much time do I have to talk about myself? It's my favorite thing to do in the world.
Let's go.
Timekeeper, yes.
So I'm Shawn. I'm here from Minneapolis. Yes, indeed, we shoveled our driveway yesterday. For those of you who like snow. And I am part of what we think is a tremendous opportunity to change things at Bind. Hopefully I'll convince a few of you that we are onto something. I definitely encourage all of you. People ask me about competition, etc. The more the merrier, right? The problem's so big. So that's just in general my approach to things.
Sorry.
I don't have that cool of a ringtone. But I am from Minneapolis. My roots, my family's farmed the same cropland in rural Nebraska since 1882. So in terms of who to identify with and who am I, at heart I'm a farm kid from rural Nebraska. My formative years were spent in the U.S. Army. I was on tanks and led an infantry platoon. So that's me. And then I found healthcare. I found healthcare, probably a lot of you similarly. My dad developed bladder cancer from rural Nebraska, no insurance. You run into healthcare pretty quickly and all the problems with it, and you get motivated to change it. So that's why I got into it. That's why I'm here.
Thank you.
Thank you for sharing that personal story. What does Bind do, and why did you arrive there?
Sure. So Bind is a new health insurance company with a new health insurance benefit product design. We arrived there because after several years, Abir, who's in the back, will be up here, he's really one of the last ones that actually has created a new product in health insurance. So Abir was part of the team that created the account-based plan with a deductible layer. He never intended it for it to get where it is today. So the last pioneer of health insurance product is actually in the room with us, so we should definitely give him a hand for what he's done. That was how long ago, Abir?
1998 was when we started, so
Wow.
20 years ago.
Yeah, so 20 years ago is the last time think about that. The last time we had a new product in health insurance was 20 years ago. Probably time for something new. So we said, okay, I think in order to disrupt, transform, improve health insurance, you can't throw a nice customer service layer on it and treat people really well and take puppies for them to pet to an open enrollment meeting. You can't just think you're going to use data on a broken underlying insurance and underwriting scheme. So we said in order to create something better, we think we probably need to create a better product. So we start from the product perspective. The product we created eliminates things that we think are actually not very useful, valuable, and don't get the results we want. So we've eliminated deductibles and co-insurance layers from our product, so everything then has a price tag. When everything has a price tag that actually means something and is certain, you actually can give people that information and allow them and turn them into what the superpower of America, one of them, which is consumerism. So if you can actually give them a price, people know how to shop. You couple that with an easy benefit without co-insurance deductibles and give them clear answers on coverage. They can actually use another superpower, which is everyone knows how to search Google. You give them the ability to search Google for something's covered, and you return prices to them. They can make better decisions, which is what we've seen. So that's the heart of what Bind is a new insurance product.
So you touched on, and obviously we love that theme, right? Empowering consumers. So do you think the fundamental problem of healthcare insurance is because consumers have just been so far away from the actual finances of the buying of the services? That's been and we need to empower them.
Yeah, so I certainly think, so I'm a believer that throughout history, if you're on the side of the people eventually always win, whether it's pick your favorite revolution or pick your favorite consumer movement. So if you're on the side of people eventually always win. So I definitely believe that empowering people and giving them what they need, they will win in the end. And I definitely believe that they haven't been given the power. So you just start with, and you said it, most people in this country get their benefit through somebody that they are employed by. Mm-hmm. And it's not as if the people they are employed by said, you go pick what you want. Go pick if you want Anthem, Aetna, and decide what's in here. They actually pre-sort and tell you your options. So that's removed step one. And then remove step two, because of the insurance levers we've introduced to them, they have no idea ahead of consumption what something might cost them, what's the impact to them. Because the way we've constructed it, you go in, you have a conversation, you might have a lab panel, et cetera. Then somebody codes it, and then somebody makes sure the codes are optimized for reimbursement. Then you might fight with the people that pay it, and then eventually a couple months later you get a bill. So they're definitely removed from the purchasing of healthcare. They have no idea to get an answer on what it cost.
I have a follow-up on that, right? And I talked about how consumers need to be much more involved, right? But Archana and I have spoken about this many times, is like, I really like checking out new books or new movies on Amazon. I like that interaction. I like that interface. I don't go like, I want to go and log into my health insurance portal. And I'm not quite sure that engagement, like what have you seen in terms of how you're getting people to be engaged in insurance, right? Or, well, maybe it's, you don't call it insurance, we're just calling it insurance, and maybe you're calling it health services. Maybe we have to get that term out of there. But what are you actually seeing in terms of a change in consumer behavior?
Sure. So it goes back to starting with the product. So I'll get into another element of the product to answer this question, which is another one of the flaws that we saw early on was, if you go look at the consumption patterns and what is insurance really funding, essentially insurance covers nearly everything. And when you look at the properties and what insurance is meant for, insurance is fundamentally designed for low frequency, high cost events that are unforeseen. If you look at your insurance coverage today, is everything that's covered by your insurance low frequency, high cost, and unforeseen? I think the answer is no.
The health insurance industry is the only insurance industry in which we get wellness visits and health maintenance things be covered by health insurance, and then the catastrophic is a whole different discussion that we can have. Yes.
Yeah, and some of the maintenance stuff is important. So there's maintenance stuff that other insurance policy types also cover. I mean, maintenance stuff does help improve the risk of the pool. So it does make sense that the pool invests in maintenance services. It doesn't make sense for them to invest in the equivalent of a new kitchen. That's not, your homeowner's policy doesn't fund that. That's the equivalent in healthcare of getting a discretionary service or a discretionary procedure that's no better than not doing anything. And oh, by the way, puts you at risk of becoming a lifetime opiate addict and potentially maims you for the rest of your life. So we're mixing different services that you provide coverage for. We're mixing things that are truly insurable, catastrophic. I can't detect and predict that I'm going to have a heart attack. We should probably pool our money to help people pay for that when it happens. But I can predict and think about whether or not I should have a $130,000 lumbar fusion. That evidence would suggest is no better than a regimen of PT. That looks more like a discretionary purchase, and nowhere else in insurance are we, the pool, funding someone's discretionary purchase. Doesn't make sense. So we stopped it. We created a product where 45 plannable procedures are available for coverage on demand. And we don't tax the group and those that are enrolled in the plan for the cost of those things the whole year through or several years through. You can actually buy coverage for those things when you actually need it, when your needs change, and after your clinical team and your friends and family have worked with you and convinced you that you should purchase it. So we've introduced a new concept of coverage, which is I can buy coverage for things in healthcare on demand, but I don't have to saddle myself with the cost the whole way through, which in the positive frame of that is I'm able to give myself a pay raise when I go on Vine's insurance. And I buy what I need when I need it.
So follow-up question to that, and also kind of related to what I see what buying does is you buy what you need and what you anticipate needing. So you're kind of customizing your insurance plan based on your own physical and mental health need. In that case, let's say we have a cohort of, or a population of, 50,000 people. We can divide in 3 risk pools, and you could say, hey, young invincible may not need to pay that much, and then the middle of with some disease management has to pay midway, and then some folks who are unfortunately suffering from cancer or some other chronic disease that requires is a higher risk pool. How does Bind today? Most insurances, they have kind of spread out the risk, and so that's why the cost point for most people is more even. How does Bind do that for this 3 sets of risk pools, and how do you manage risk on that population?
Sure. So risk management, a rousing topic. I'm sure all of you came for this one.
This exact one, yes.
So we don't split risk like that. We don't split risk into young invincible and people that have chronic conditions. So that would actually defeat the purposes of pooling risk. So the risk is still pooled. You still assume a certain level of utilization for that pooled risk. But what we do is different on the how the investment comes from the pool. So today, if you looked at actually the math that goes on behind each of your insurance policies, everybody knows you pay a premium. Everybody knows their premium. Maybe you don't know enough, but you could go and find out what your premium is. If you went to the insurance company, they would be able to break down your premium to say 5 cents of your premium is going toward the pool's use and consumption of cancer services. Another 5 cents goes toward the pool's use of orthopedic procedures. So that's how premium gets broken down. And everyone basically subsidizes it at the same rate. Our belief at Bind is that, going back to things that are more discretionary, we should not fund those at the same rate. Those people that want to consume them, and because they're discretionary, should actually fund more of it. So what that looks like underwriting at a Bind perspective is, for those 45 surgical procedures, instead of asking everyone in the group to pay 5 cents to consume them, we're asking everybody in the group to pay 1/4 cent. And then if you do consume one of them, you actually then pay more into the group, let's say $1.25. So our version is not, we're not splitting the risk pool. We're changing the subsidization, which is a fancy word that we use to basically, it's the investment of the group's money toward helping someone purchase services.
So,
Did that make sense, everyone?
No.
Great.
Question? Yes.
So, as she knows, I came from the payer purchaser side, and I actually did innovate 11 different healthcare products and insurance products. So I applaud what you're doing, and I know how difficult it is. But my question is that some people don't just start a discretionary. In fact, I think most people don't. A lot of people want to avoid surgery, so they might try a whole slew of cortisone shots and lots of different types of PT and even acupuncture and chiropractic and all these different things that are both mainstream and not. And then they eventually get to the point where nothing's worked and they have to get surgery. So if you've got somebody who's done that build up and they've started with the least intensive care and they've worked their way up, are they still going to pay the same thing as the person that jumps right to the surgical modality?
Yeah, great question. So if I've tried everything and they absolutely didn't work and now this thing is no longer discretionary, do I pay the same? Now that gives me the opportunity to introduce another part of the benefit, which is, I said everything has a price tag. That doesn't mean everywhere you go and every doctor you use has the same price.
Right.
So I'm sure there are other clinicians in the room, but my guess is, if they are, would you say that every clinician performs at the same level?
No.
Nope.
So should we have all clinicians priced the same way? No.
Yeah. No.
So my answer is, depends on where they go for their procedure. So
what came before doesn't really matter. It's more the site of care and the price that's charged.
what came before doesn't matter for the people on the plan today. A year from now, it will matter. So we will be adjust. So we have, and it depends on the service. So today there are some services. An example we have today. So unbeknownst to most people, the pharmacy formulary, the PBM formularies have inherent bias toward different populations of people based on what therapeutics work for people. And some therapeutics are in a higher tier, and those therapeutics only work for certain types of people. And race is a factor, so they're inherently biased. So what we've done, for example, on therapeutics is, if you've tried the tier 1 therapeutic, and now that therapeutic no longer works for you, and you have to move to the tier 2 therapeutic, and everyone knows if you move from tier 1 to tier 2, what happens to your cost of the therapeutic? Goes up. Doesn't make any sense, right? That's the only thing that works for them. So at Bind, what we do is the tier 2 therapeutic is moved to the tier 1 copay, or tier 1 price. So we're doing it today, just not for the surgery you asked about. But we are doing, we call it contextual coverage. What you've tried before in your context of you as a person, your insurance flexes based on your context.
That's great.
Okay. Jose?
Jose.
Hi, my name is Dr. Jose Bolaños. I'm actually Stanford OBGYN physician in practice for 21 years. So I've seen insurance companies from the beginning when it was 80-20. You know, insurance companies pay 80%, patients pay 20%. And the costs were really low. A day in the hospital was $1,200. And then, you know, the HMOs came in. Then all of a sudden there's been such a mutation of coverage in such a way that obviously they don't want to pay. And the cost of healthcare is really fascinating because the prices are actually fraudulent. For an insurance company to actually, as a doctor, to see patients from a particular insurance company, you have to agree to their reimbursement schedule. And usually they pay doctors 40 cents on the dollar. For a hospital, you have to do the same thing, so they're negotiated rates, but the payment to a hospital is like 10 cents on the dollar. So a day in the hospital for a cash paying consumer is like $25,000, but the insurance company pays $2,500. So the entire ecosystem works on having to be contracted with an insurance company and to, you know, you're held hostage to the rates they're going to pay you. And obviously some of these medications are so darn expensive. Who's your reinsurer? Are you like with Lloyd's of London on some of this, or are you using HSAs? And do you guys have a network contracted for discounts? Because again, you go to a hospital and a particular, what we used to do was this. When I'd have a fertility patient, if I did surgery on them, and you didn't agree with prices, it might cost $25,000. What we used to do is almost like concierge. We'd call the hospital and say, we need an hour of surgery. Will you do it for $1,500? And then they'd say yes. The anesthesiologist $500. We charge $2,500. So we'd have documents where patients can go in and prepay their service, and so then that way they'd get the surgery for $6,500, not $25,000. So the monster you guys are dealing with is this incredible deviation of even a normal supply chain process. Right? It's like there's some vendors that are making 2,000% on their drugs, and so the difficulty is, you make it sound really easy. Like, we'll tell you what you're going to pay, or you might say, hey, the normal fee is X. But when you're dealing with hospitals and emergency rooms, one of the things we found was the network discounts was really frightening. You can go to the emergency room, and the doctors in the emergency room are no longer part of the network.
Yep.
And so there's this mess that poor consumers are stuck with thousands of dollars of bills.
Doesn't make any sense.
Yeah.
That's why we give everyone a price that they know in advance, and it's with certainty. So if you go to an emergency department, we tell you it's $300. If you have an out-of-network clinician that sees you at the emergency department, it's $300. If you get a cast, it's $300. If you have to have the most expensive lab panel known to all of us, and it goes out-of-network for the lab, $300. So the complexity that you're dealing with is what we're trying to take on. The complexity should not be borne by all of us.
Right.
So
The vessel to bear the complexity is the insurance company.
Does the doctor send you an actual HICFA 1500 form? Like
Yeah, absolutely. Yes, absolutely.
It's the same billing process.
Yep.
As part of your question too, how are you negotiating with the hospitals differently than some of the
Then the
other
cash
insurance
pay,
companies?
for example, or yes.
How are you negotiating with them differently than sort of traditional insurance companies, that you're getting better prices or more transparency?
Sure. So, again, if you just go back to the concept of, if you're on the side of the people always win. So we believe that time is always the question of when do they win. If you give people information that's useful to them, they will optimize their decision to them, and we believe that when they optimize the decision that's right for them, it typically, in most instances, is going to be advantageous to all the rest of us that are helping them with that purchase, because we're all pooling our money together in an insurance pool. When you do that enough, and you give people enough information, so again, if everything has a price tag, and I can give them that price tag on their most used device, their cell phone, and that price tag is certain, I go to the doctor, and the phone told me it was $25, and I no longer have an out-of-network lab bill, and a this and a that bill. It's $25. They start to trust us a little more, and then they use the phone over and over. What happens to a competitive dynamic where now the clinicians and those organizations that are attracting more people because of this versus those that don't? I'll give you an example. Is that time's up, or somebody else is calling?
I think Bambi says time is up.
It's time's up.
So here's an example.
Yes.
There are
Let's do that.
Actually, that worked out well.
Yes.
Excellent.
Yeah.
Okay.
So
we
as
create
you're going,
competitive dynamics.
Yes.
So we have practitioners like you that call us to say things like, "Hey, you have a big customer in my town. I'm really interested to know how I can get my physical therapy prices down to $30, because I've noticed not as many people are coming to physical therapy, which we all know is really a feeder to other things like surgeries. And I'm understanding that maybe a cause of my down in what's happening to my finances maybe is rooted with you. So could we think about a new way to do business so I can get my price to $30? That's happening.
So in other words,
Competition works.
if one of your patients comes to see me and they say, "Oh, my office visit is $40," and I'm going like, "Wait a minute,
No, you still submit your claims. You do everything you want to do.
right?"
I know behind the scenes, I've done a lot of math to figure out how much I should.
My fee's 80. You're telling me it's 40.
No.
patient sees
What their
it.
price is 40. Their price to access you is $40.
The patient's
Not what you get
copay is
reimbursed.
$40. Yes.
Oh, I see.
All that complicated stuff behind,
Yes.
we're doing math behind the scenes to set your price
Yes.
based on your total value calculation.
Almost like a copay, in other words.
Oh, it is a
Yes, it is a
copay.
copay, yes.
Okay, cool.
You have a question?
It's a price.
Yes.
How do you make money?
Oh,
You make money as buying.
Sure.
You're doing such great, sorry.
I will come to you right after that. Yes.
Oh, I
Yeah. Oh, that's okay. That's okay. Yes. How do you make money?
So today, so we're a venture-backed company. We very deliberately
Venture
started
capitalist.
You raised what, 17
Hey.
million?
more than that, not important.
Yes.
We deliberately started in the self-insured market. So we make money, we get a flat administrative fee to manage benefits for places like HP. Today.
Full disclosure, not yet. So
I said like HP. I said like, everyone heard me say like HP.
yes, like HP. Yes. Yes.
That's why he's
Yes.
here.
I just want to put it out there. Yes. Like HP is a good
conversation. We can do a couple of questions because then
Yes.
we're over time, but
Yes. You gentleman is sitting there for.
And that kind of got to my question.
Yeah.
You guys, a TPA that works with some
Yes.
employers,
Yeah.
and not a full insurance carrier, and then so you have to work with United to the World in some way. Oh, you have to work with United to the World in some way to build your network. So how do you think about that today, and then how does that evolve over time? Obviously, you have to start somewhere.
Sure, and that is exactly right. You have to start somewhere. So venture-backed companies go through 3 phases. You have to prove someone will buy it. You have to prove a whole lot of people will buy it. And then you have to prove that a whole lot of people will buy it, and you can make money giving it to them. So first you have to prove people will buy it. It's pretty hard to build a network. I mean, the first time, I don't know how many do this, but you should try it out. It's pretty fun. Do a field trip to a hospital setting, system. Go talk to their VP of revenue cycle and tell them you want to enter into a contractual arrangement with them. What kind of rates are you going to give me? And their first question is, how many members do you have, and how many are going to deliver to my front door?
Yeah.
When you're starting out, guess what the answer is? 0 and 0. So yes, you have to partner with existing players. So we've got our start. I'm from Minneapolis, and we got our start with a local regional plan operated by one of the large integrated delivery systems there to get started. When you get started and prove things will work, then other people get interested. We had conversations with several large national companies that happen to own competitive networks. One was more aggressive and enthusiastic than the others, and so we have partnered with United Healthcare as our national network.
Great.
Yes.
One in the back and then you. Yes.
A beer can have a
Yeah.
question. No
Yeah.
way.
Question. Obviously, fan of what you guys are doing. The 45 conditions that you talk about, in your analysis, what % of the total cost does that represent?
Sure. So Abir is asking for the 45 services that are plannable procedures, meaning I've got time to think about, should I do the surgery or should I do watchful waiting? Should I go to this place or that ASC? Should I go to that surgeon or this surgeon? So you've got time to plan for them. There are 45 of them today, and they, depending on utilization patterns of the group, will be from 20 to 30% of their total spend.
Oh, that's big.
So it's material, for sure.
Material.
And what we've seen to date is when you give people information, not only information on price, but when they go to purchase one of these, and on demand, so you could start your plan year January 1st, you can buy coverage for a hip surgery December 31st. It truly is on demand. I can, on my phone, sign up for coverage for this when my house is on fire, basically.
Really?
So,
You need surgery?
you actually have to actively enroll. Everything has a price. So if you go to one location versus another, the prices will differ. Before you get into the prices, though, we let you know that your coverage also has things that, again, going back to the power of the American consumer, Amazon, people like you have tried these things or bought these things. We let them know. Hey, you're looking for a lumbar fusion? People like you have tried physical therapy, have tried pain injections. And what we've seen is that on our plan to date, we have 40% less consumption of those 45 surgeries. And when they do proceed with the surgery, 90% occur at the lowest quintile of cost and high quality.
That's fantastic. So you're actually sharing risk with the patient. The patients are assuming a certain amount of decision-making risk at this time.
again, we fundamentally believe that
Yes.
people are a lot more, they're a lot smarter than we give them credit for. And they're the best manager of their own situation and risk. And if the problem is they've been given not very good insurance products, that I don't care how great your data and transparency tool is, it's not going to be very helpful to them. So that's why we start with the product. You give them a product and information, a product they can understand, and information they need to use it, they'll use it effectively, and it benefits everybody. And we've seen that.
We actually have.
We will have
we're
Shawn
actually
back.
Going to bring
Yes.
Shawn back.
Yes.
When we bring everyone back, so I think we'll stop you here because we have to go into the.
Yes, it's buying.com.
Yourbuying.com.
Yourbuying.com.
Okay, so.
Yes.
Wait, we're not off to break just yet. Archana is going to speak, and so is Anthony. So give us 5 minutes. Give her or them 5 minutes.
No, mine is mine is on the bottom. Yeah. Okay, so this wasn't supposed to be my part, but I'm going to do this because HP is sponsoring today's event. And as we are talking about the reality, which is insurance, I want to talk about reinvent reality the HP way. And I would need technical help.
I think you could just.
You should not ask an MD to do a technical conversation.
Is this the reality part?
Yes, this is the reality part. And then I'm gonna where's the mouse?
It's on this big screen.
It's on the big screen. Okay, so can I?
There we go.
Oh yes, here we go. So let's talk about extended reality. So we're talking about the reality, and I want to talk about extended reality because every time we focus on one key product that HP is forging into the healthcare space, and this is one of the products that no other company is making towards a commercial grade virtual reality product. So let's kind of get to the school of what extended reality means. There's one that's virtual reality in which you go in an immersive space. You have a head mount display, which is called HMD. I learned it. That's the word for it. And then you get to see places, whether it's a snow-covered mountain, or it could be a Disneyland. It could be cartoon characters in there too. Then augmented reality is where you are walking in a room like this, and then content and words keep coming around you, and that's the AR, which is more Apple is working in that space. And then modified reality is where you're actually putting structures and things in the real space. So those are kind of three different kinds of reality that we have a lot of innovations happening. But I want to talk about HP and head mount display or devices. HP is the tier 2, which is the $2 sign, so to say. So it's affordable. It's clean. It can be cleaned. It's scalable because it's less cost. And it actually is the only consumer product, only commercial product out there that is utilized in the healthcare space. And it's not just in the healthcare space. And just so you know, a few things compared to even last year's model to now, we are able to see a 90 frame per second changes, and that kind of changes the clarity of these visuals. And that's important because most of us, if you have experienced a VR device, you feel dizzy quite a bit. And that happens because they are somewhat blurry and you're trying to focus on little pixels, and that gets better as the technology has improved. And the focus is to really touch all of the senses of human experience, whether it's tactile or hearing, touch, taste. That doesn't mean that it actually comes through the headset, but the visuals are creating those experiences. And they're doing some EEG testing, and they're seeing that if they see a nice cup of coffee, it's triggering the taste sensation in your brain. So the segment solutions that HP is doing is architecture and automotive. So BMW and Audi have VR sets that HP provides in which you can actually custom build your car and you kind of get inside it and you can touch and feel all of the things. Training is a big aspect. So people who are remote, and a lot of global companies are remote, they can send a VR set and then people can touch and feel what they're training their folks for. Healthcare is what I will be focusing today. And then location-based entertainment. So, you know, Disney and other folks, they actually do quite a bit of VR entertainment. All right, so let's talk about healthcare. And I want to begin with surgical planning. So there are two products that go towards the provider and two products that are patient-facing. So there are companies that have built products that go on the VR in which they train physicians to learn how to perform surgeries. Medical education. So a lot of our medical students, they could be remote. I actually saw a product at UCSF at the DocSF conference in which a provider who is very proficient in doing neck surgeries in UK uses a VR product, and people from all over the world log into his VR real-time presentation and can learn key techniques of doing surgery for those folks. So it is improving efficiency and helping people to be more accurate. This medical education module is also utilized for nurses. So when they are, before they even go to the operating room, they get to see these devices, how it's laid out. What is each of these instruments called? And that helps with medical error in the operating room. Patient-facing, so virtual reality therapy, and I'll go a little bit in detail. It actually focuses on pain today, a lot on pain, especially in the opioid time, and then also focuses on senior care and caregiver training. So this is another important. And then integrated wellness. So we do look at kids who need a flu shot. They're put on a VR device and they can get a flu shot while they're getting distracted. So those are a few other ways that we have utilized. Some of the data points that actually came out of the HP VR set, there's a 6-minute reduction in OR time. Do you know that every minute of OR is about $100 on an average in the country? So if you have 6-minute reduction, that's a significant dollar cost saving for folks. 30% reduction in pain for people who could be on medication, and 20% less opioid use if they are utilizing VR technology. There's 3x 5-minute experiences that can replace 60 minutes of training for medical students and nurses. And it's about 1.5 hours of real-time procedures that can be, 1.5 hours that condenses about 36 hours of real-time procedures for training for surgeons. So, as you could see, Embodied Labs actually had a training program for caregivers. So these folks who are helping seniors with Alzheimer's, seniors with Parkinson's, they are put on a VR immersive experience in which they have Alzheimer's or they have Parkinson's, and they experience the life of this patient and develop empathy and is able to care for their patient better. The other one is a DEMA Lab. So the DEMA Lab project was more focused on cultural sensitivity. So this lady who was who was suffering from dementia and Parkinson's disease culturally was very different from her caregiver. And so her life was picturized in a VR space and was shown to the caregiver so they could be more culturally sensitive to her needs in a residential community. Another place that we have seen a very impactful result is in our older adults. So they are not ambulatory, so they can't go out outside in a park. They cannot go outside in places they love to go, Starbucks coffee, whatever it is. They actually create immersive experience for folks who are in a nursing home. And once they do this immersive experience, their depression, their anxiety level, and their sundowning is better. And the same thing that they saw in UK studies in which people with dementia were given their old memories through the VR experience, and that helped them to recover some of the relatability to other people the family members who were coming in. By giving them the experience, we were able to have them talk to their family members. So health and wellness, we did talk about how, firsthand technology, that's a HP partner. They have built, health and wellness solutions. One is definitely that flu shot thing, but also prior to surgery, people are very anxious, so they're given an immersive experience to either distract them, to bring them into a snow-covered mountain, and that helps to cool down their anxiety. As you could see, that's kind of similar environment that kids can actually see. There are pancreatic cancer and other cancer patients who were given this VR experience at Providence Cancer Institute, and that helped to decrease their opioid use by 20%. And that's quite significant from my perspective as a physician, if my patients can be relieved off of this. This was what I was talking about, medical simulation and training for pre-operative nurses. It decreased their medical error and improved their training in their operating room, which is really critical because your success rate of the surgery, but also infectious rate, decreases if the nurses are better trained. Oh, there was a video. Okay. Technical difficulties again. It is playing here, but it's not playing there. I'm going to pass through the video. I want to just do the last video that I will bring you guys up to. It's not advancing.
Let's go back to
okay. I need an immersive experience to learn to do this.
Oh, there it started.
Okay. No, we're going to pass through it. So peri-op sim, this is the nurse training solution that is through HP, surgical planning. So most of us see images in 2D. So most of us, like physicians, but you also see X-rays and MRI in 2D. And when we are actually operating on the brain, for example, it does become really vital to kind of practice ahead of time and see a 3D image and have an immersive experience. So folks, the physicians, they are all surgeons kind of sitting there, and they go inside the brain and go to the area where they have to clip an aneurysm, for example, in this case, and learn that through an imaging immersive experience, and then they go in and do the surgery. So not only it's timed less, but also they do a more precise surgery for the folks. As you can see, this is the company that partners with HP Surgical Theater, and they're able to practice this ahead of time, right before going into the OR. So these are all of the healthcare use cases of VR. I wanted to show you a video that we keep reinventing, by the way, of all of these solutions. So I wanted to show you a video that I found was quite impactful, and if you can help me with that again. So I want to end with a video of a lady who went through, and this is a true patient, who went through an accident, was hit by a truck, and had to go on surgery and had a lot of pain.
I'm not technical.
You're not technical either.
I wonder if we can share.
If you go back to the previous setting that we were doing, yes.
Right?
Almost. Okay.
Since we
So
basically, I want to.
Anyways,
are you ready?
Yes. Well,
Okay.
I'm going to hold off on the video because it's obviously not working. But thank you so much for hearing through it. And I wanted to invite our other, by the way, that's a picture that I took in Zermatt, the Toblerone Mountain right there. Okay, just bragging rights. Yes, here you go.
What kind of camera?
iPhone.
Oh.
Well,
Great
when you're
picture.
hiking like 20 miles in the Swiss Alps, you just need an iPhone.
That's awesome.
Yes.
Hi, everyone. My name is Anthony Schell. I'm a principal with Avis & Young. We're commercial office brokers for technology companies, startup to Fortune 50. I've been a partner of Vator and Invent Health and HP and UCSF since the inception, and we've been so grateful to be a partner. Thank you to Bambi and to Archana and to HP and UCSF for this wonderful event and space. I am going to go really quickly because I just want everyone to get back to that amazing spread right back there for the break. But I wanted to touch on something. I've been doing office leasing for technology companies for 15 years. And for a long time, my only goal was to find out how can I give my clients the coolest space so that they can win that war for talent. When they search to find employees, how can they find a way? And at first, it was cool accent walls and go-kart tracks in the space. And then it shifted more to kind of in-office gyms or yoga rooms or meditation rooms or wellness rooms. And really recently, we have shifted our focus to what impact wellness programs have on employees. Are they accepted by employees? Do employees like it when an employer offers a wellness program? And what kind of office space can kind of play into helping a wellness program be successful? So I've been looking for a data set that would allow me to speak to some level of understanding of this versus just saying, it's really cool and my clients use it and they love it. The RAND report was a report done by the RAND Corporation, who is a very large nonprofit organization who does research across many different areas. But this area was specifically on the adoption of wellness programs in the United States. They looked at a variety of different factors and what went into it. What was the evidence of program impact? What are the characteristics of different programs? The main takeaway is that we are seeing a giant jump in wellness programs being offered by employers. Over 50% of corporations in the United States now offer some type of wellness program, which I think is really a great step in the right direction for employers. We obviously see a bit of the buzzword in commercial real estate or office space is that, I shouldn't say the buzzword, but that sitting is the new smoking. We've heard that a lot. That's why sit-stand desks have become very popular in the workplace. And what I found was also really interesting about the takeaway from this massive report was that they found that lifestyle management programs in conjunction with wellness programs offered by employers really have long-term benefits. As employers in this room to your various companies, I thought that this information might be relevant. I think that we all know there's a lot of lifestyle-related diseases in the United States, and we find that sitting in an office all day is obviously not good for you. So I think that the adoption of of different wellness programs is critical. Lastly, on what role incentives have on the adoption of wellness programs, I found this metric really interesting. Limited engagement obviously is still a big block to getting wellness programs really inputted into the general masses. Employees sometimes don't seem to be very interested in them, and employee participation seems to be fairly low in some cases, but when offering incentives through an HRA, that number jumped, and when trying to find the dollar amount of what the incentive would need to be to see an adoption, it was anything above $5 a year, really spurred forward adoption, which I found was crazy, crazy low. As such, I think it's critical that we, as employers of teams of people, find office buildings that have gyms or healthy work environments in them so we can combine healthy lifestyle choices along with wellness programs. And there's still a ton of data still to be collected. It was only a 6-year study, this RAND report, so still a lot more to be collected, and a broader range of measures needs to be studied. But the main takeaway from the 6-year report across most corporations in the United States was that wellness programs are being adopted at quite a fast clip, and that anything above $5 in terms of incentives will get your employees to sign up. So if anyone has any questions about workplace strategy, wellness initiatives, or what a healthy building environment might look like, I'd welcome any questions after the break, of course. Thanks again, and enjoy.
We're going to cut the break.
Cut the break to 10 minutes.
10 minutes.
No.
Back here at 6:35.
Yes.
Yes, 10 minutes. Enjoy the break, and thanks again.
Yes. Awesome.